right. Hello. Let's talk about antidepressants. Antidepressants are a really important piece of treatment for depression and anxiety and related disorders, but they are not without cautions and concerns. So, the first thing to talk about is the boxed warning that is associated with all antidepressants. So, this is one of the higher levels of warning that the FDA will apply to a product or products. And this warning has to do with risk of suicidality. So, which that's a concern because that's one of the things we're trying to prevent as a goal of treatment when we start antidepressants. It is important to note, though, that this is with a specific group of people. So children, adolescents, and young adults, 24 years of age and younger. So in that population, we will often be a little bit more hesitant to start an antidepressant. We'll be more quick to change an antidepressant, monitor it more closely, and provide education about, hey, if you start this medication and it actually makes you feel way worse, that's something we need to know about, right? So there's a number of theories as to why antidepressants can sometimes cause kind of the opposite effect. And the first theory, of course, is brains are weird. We don't fully understand brains. So sometimes, despite a dearth of evidence that antidepressants are beneficial, there are some people where it's not. And it's really hard to know which people those are. The other piece that is important to remember is when you think about the types of symptoms, it's not just one symptom that someone has that would diagnose them with depression. It's oftentimes 6 or 7 types of symptoms, and they may be of differing degrees and differing levels of concern. So what can happen is we start a medication and maybe this person has suicidality and they also have fatigue and lack of concentration and lack of motivation. And we treat the fatigue and the lack of motivation and the lack of concentration, but we haven't quite treated the suicidality yet, right? So I've had plenty of people who've mentioned that they were suicidal or had thoughts of death, but were too tired, just didn't have the energy or the motivation to actually act upon that. So that is a recipe for a challenge if we treat that piece and they still have suicidality. There also could be diagnostic issues because the brain is still developing significantly up through around the age of 25. It's not like there's an oven timer at 25. Ding, it's done. But 24 years of age and younger, they are still developing, right? Their brains are still developing. So there could be an underlying other condition that is being treated poorly with antidepressants. There could be a rare influence that antidepressants have on their neurobiology that we don't understand. Who knows, right? It's hard to know for sure. It's pretty rare, but it is a warning that we have. The other piece to take into consideration that's also quite rare, but you'll hear about, is serotonin syndrome. And serotonin syndrome is a triad of, essentially a triad of symptoms that we see when someone has basically toxic amounts of serotonin in their brain. And everyone's sort of limit for serotonin seems to be a bit different. Usually it's not one medication though. Oftentimes it's in overdose situations or if someone's taking multiple medications that increase the availability of serotonin. And someone might have milder symptoms like they feel sweaty and their heart's racing and they feel really sick and they might be more sensitive to serotonin. But the serious form of serotonin toxicity is a serotonin syndrome where they can have significant mental status changes. Their blood pressure and heart rate can go up and down and up and down. Their temperature goes up, their body temperature goes up, they get hyperthermic. They can have these muscle spasms, so like myoclonic jerks where their joints jerk essentially. And this can potentially be dangerous. We can stop the medication. It usually goes away pretty quickly, just like it comes on pretty quickly. We might be able to lower their body temperature, control their heart rate, those types of things. But certainly something we look out for. In addition to that, I talk about this all the time with my patients, is the risk of withdrawal. So whenever we do anything to our body, our body gets used to it over time, especially if we do it slowly, right? Any big change you adjust to more poorly than a slow change. And this is true for your sleep cycle. This is true for your activity level. This is true for the foods that you use to nourish your body. And when you start an antidepressant, usually we start at a low dose and we slowly go up. You might have some side effects at first. A lot of times those side effects go away. But if you suddenly stop, your body's like, this thing that I'm used to is no longer here. And you can feel sick, right? It doesn't mean that someone has like antidepressant use disorder or anything like that. There's no, none of that behavioral component of risky use and et cetera. But you can experience these types of symptoms if you like mnemonics, you finish your antidepressant too soon. Right. So we can see flu-like symptoms. So that chill, fever kind of feeling, difficulty sleeping, nausea, stomach upset, irritability, sensory disturbances. Particularly, I educate on what's called brain zaps, which is kind of a sensation like when you touch a doorknob and you get that little static discharge. It's like that, but in your brain. Not dangerous, has not been associated with anything that could harm someone. But if they're not aware that that can happen, then it can be quite scary. It can happen without being on an antidepressant, but the most common way with which someone might experience a brain zap is through antidepressant withdrawal. And we also see things like headaches. They're usually self-limiting, but can be pretty uncomfortable. So making sure if someone is coming off of an antidepressant, that they're aware they should come down slowly if at all possible. So I'm going to introduce the types of antidepressants, and then in the next video, we'll talk about those types of antidepressants more in chunks, right? So there are a number of different products that can be used to treat depression. So we have our SSRIs, or selective serotonin reuptake inhibitors, our SNRIs, or serotonin norepinephrine reuptake inhibitors. We have kind of two, we'll talk about it, NDRI, so norepinephrine dopamine reuptake inhibitor. We have a NASA, this is quite the acronym, but it's a noradrenergic and specific serotonergic antidepressant. We have our serotonin antagonist and reuptake inhibitors. So the pharmacology is a little bit different than an SSRI. We call them SARIs and SPARIs. We have tricyclic antidepressants, which break the mold by referring to their chemical structure instead of their mechanism of action, because I guess they just wanted to be different. No, they're older too. And then monoamine oxidase inhibitors, or MAOIs. And then there's a couple miscellaneous agents that we'll talk about, like esketamine, etc. So we'll talk about those in the next video.